Let me welcome you to part 2 of our discussion about Alpha-1 Antitrypsin Deficiency. Again, I'm Jamie Stoller, a member of the Respiratory Institute, Pulmonary Critical Care, doctor at the Cleveland Clinic, and serve as chairman of our Education Institute. In part 2 of this series, I'd like to discuss the clinical features of individuals with Alpha-1 Antitrypsin Deficiency, or AAT deficiency, and the natural history of this disorder. In thinking about the clinical manifestations, this is really framed by 3 or 4 major clinical manifestations, the first of which is chronic obstructive pulmonary disease, or COPD, which may present as either emphysema, chronic bronchitis with chronic daily phlegm for at least 3 months duration, and even bronchiectasis, dilatation and often infection of the dilated airways. The second major manifestation is that of chronic liver disease, which may be cirrhosis, fibrosis, chronic hepatitis, or even an increased risk of hepatoma or hepatocellular carcinoma. An uncommon but clearly related manifestation is that of paniculitis, an inflammatory condition of the skin, characteristically causing, as shown here, painful nodular lesions which may weep and migrate over time. And lastly, a fascinating association with C-ANCA-positive vasculitis, which we now call granulomatosis with polyangiitis, GPA, previously referred to as Wegener's granulomatosis. We won't be discussing this association much, except perhaps at this point to say that the mechanism is speculative, but because alpha-1 antitrypsin binds proteinase 3, it's felt that the association with vasculitis may be related to the deficiency of alpha-1 and therefore the inadequate binding of proteinase 3, which allows proteinase 3 to be more expressive, if you will, resulting in the resulting vasculitis. Now, prior to the results of the largest available multi-center trial, the NIH Registry, the results or a picture of alpha-1 antitrypsin was framed by a study by Larson and colleagues in which some individuals, some 246 individuals who were severely deficient, were characterized. And as you can see as shown here, 3/4 of those individuals were said to have COPD, about equally divided between those with emphysema and those with chronic bronchitis. About 3% were said to have asthma, about 11% said to have bronchiectasis. About 12% of these individuals were felt to have liver disease, most commonly cirrhosis, but you can see with some degree, some frequency of hepatoma as well. Now, I will share with you the results of this registry because they have been seminal. These are data that go back to the late 80s and mid-90s at this point, but they have been seminal because of its being a large longitudinal observational cohort study in helping us to define both the clinical features and natural history of individuals with alpha-1 antitrypsin deficiency. Again, as we'll discuss in part 3 when we discuss therapy, this was not a randomized trial, and therefore one needs to look at analyses of therapy that come from this study with some circumspection because of the potential biases of an observational study. Recruitment to the registry was brisk and exceeded expectation, as shown in the yellow bar, which exceeds the orange bar or orange line. In total, 1,129 individuals in 37 centers participated in this registry with follow-up out to 7 years. When we look at the demographics, we can see roughly equal men and women. This is, of course, an autosomal codominant condition, so one would expect an equal gender distribution. There is noticeably a large preponderance of Caucasians. Although this disease has been described in every population in which it's been examined, the frequency is, of course, particularly of the ZZ type, is highest among individuals of Scandinavian descent, and that may account for this Caucasian predominance in this study. When we look at the age distribution, you can see that by registry eligibility criteria, the youngest individual was 18, but the oldest was 82 years old. And so even individuals with emphysema at advanced age should prompt testing for alpha-1 antitrypsin because they may have carried this diagnosis through their whole lives. Nonetheless, the mean age in the study was 46 years. And the relevance of this is that when we examine the employment status of individuals in the registry, whose mean age overall was 46 years, you can see, as shown in the blue bar, that the number of individuals who reported being retired or unemployed medically was 30%. This is a strikingly high number and reminds us of how debilitating this condition can be, in the sense that 46-year-olds are medically retired, at least 30% of them. Shown here from the registry are the distribution of phenotypes. And the take-home message, as you see in the top row, is that the vast majority of individuals who are severely deficient, which were individuals who were eligible for the registry, are of the ZZ type. There are a smattering of other deficient allelic combinations, as shown here. In total, there were 14 different allelic combinations in the registry, but well more than 95% of the severely deficient individuals are of the ZZ type, hence this being the most common and therefore the most significant to recognize variant. When one looks at lung function tests for these individuals, you can see I've listed as the row headers the forced vital capacity, FVC, the percent predicted of the FVC in the second row, the FEV1, the forced expiratory volume in 1 liter, and the percent predicted for the FEV1 in the fourth row, as well as the diffusing capacity for carbon monoxide and the percent of predicted on the bottom row. And along the column headers, the mean value is in the second to the right column, and the minimum and maximum values, respectively, are in the next to the rightmost and the rightmost column. And looking at the FEV1, for example, we see the mean value was 1.7 liters, which was 43% of predicted. There's a spectrum. The minimum FEV1 value in an individual in the registry was 7%, quite debilitated, and we know that about 11% of all lung transplants performed in this country are related to alpha-1 antitrypsin deficiency. On the other hand, there were individuals with supernormal values of FEV1. So having this genetic risk factor is a risk factor, but not an indictment, if you will. If we look at the FVC, we can see on average it was 75% predicted, so we already recognize the physiology of airflow obstruction, a decreased FEV1 to FVC ratio, and roughly proportionately decreased diffusing capacity, a measure of alveolar capillary integrity, suggesting that the lung parenchyma is damaged, as we recognize it might be in individuals with emphysema. This slide shows a histogram distribution by FEV1. So for example, in the leftmost bar, it's that small percentage of individuals whose FEV1s were between 1 and 10% predicted in the registry, et cetera, going to the right. You can see the median value, the value that separates 50% above and 50% below, was 31% predicted on the FEV1. And as shown in this vertical white line, the values to the right are all 80% predicted or above in the FEV1 relatively preserved airflow. We recognize, of course, that some of these individuals, despite having normal airflow, may by CT scan truly have emphysema. But the message is that despite having this genetic risk factor, some of the individuals, particularly if they do not smoke, have preserved normal airflow. And therefore, again, not every individual develops lung disease. When we look at the self-reported lung disease among individuals with alpha-1 antitrypsin deficiency in the registry, 83% reported having COPD, 35% reported having asthma. Now, we do know that from the registry that when serial spirometry was performed up to 3 times, and we looked at pre- and post-bronchodilator FEV1 values using the American Thoracic Society criterion of an increase of 12% and 200 ml, we know that 61% of the individuals in the registry had some component of reversible airflow obstruction, albeit an incomplete reversibility. This is true of patients with emphysema in general, as we know from older studies, the IPPB trial, et cetera. So it's not surprising that many of these individuals would report having asthma because, as I'll show you on the next slide, they may cough and wheeze, but whether they truly have asthma is arguable. There's a small frequency of pneumothorax, a small frequency in the registry, lower than in Larson's series, 2% here, 11% there, of bronchiectasis, clinical bronchiectasis. We do know that the majority of individuals on CAT scans, work from David Parr and colleagues, will have radiographic evidence of bronchiectasis. But only in that series, about 27% of individuals had clinical bronchiectasis, that is to say, chronic phlegm, copious purulent phlegm production, and the radiographic findings. When we asked individuals, 1,129 of them in the registry, what symptoms they had using a standard American Thoracic Society DLD-78 questionnaire, you can see as shown here that they really reported the very same symptoms that all of our patients with chronic obstructive pulmonary disease may present with or may be bothered by. Cough in 40%, phlegm production 46% of the time, cough and phlegm half the time, wheezing with upper respiratory tract infections or URIs 76% of the time, wheezing with shortness of breath 51% of the time, and shortness of breath, the commonest symptom, 84% of the time. The point being that these very nondescript symptoms, which may be seen in patients with usual chronic bronchitis, may also be seen in patients with alpha-1 antitrypsin deficiency, and it's very difficult to symptomatically discriminate those two groups. Hence, the importance of testing, as the guidelines suggest, and as I'll discuss in a few moments, testing every patient with fixed airflow obstruction who's symptomatic for alpha-1 antitrypsin deficiency at least once in a lifetime. Now, cigarette smoking clearly is a bad actor in alpha-1. You could imagine that because cigarette smoking recruits neutrophils to the lung as an inflammatory insult, the neutrophils recruited to the lung disgorge their neutrophil elastase and therefore increase the proteolytic burden to the lung. And in the absence of an antiprotease like alpha-1 with severe deficiency, this may accelerate the development of emphysema and symptoms of emphysema, namely dyspnea. So if one looks in these various series that look at PIZZ individuals, severely deficient individuals, and the onset of their shortness of breath stratified by whether they smoke on the left or whether they don't smoke on the right, you can see that in the most dramatic instances, that series by Giannis from New Zealand, that the onset of dyspnea is accelerated by up to 19 years in active smokers with alpha-1 antitrypsin deficiency of the ZZ type. Similarly, in the registry, focusing on the left-hand panel of this figure, those individuals not receiving augmentation therapy, this is a so-called box and whisker plot in which the horizontal white line in the figure denotes the median value, the red box, the 25 to 75% confidence interval, and the whisker, the long vertical line, the range. You can see that as a median value of FEV1% predicted on the vertical axis among non-smokers on the leftmost panel or the leftmost figure, box and whisker, that the median FEV1 value among cigarette smokers is 80% predicted, relatively preserved. Nonetheless, even among non-smokers, you could see that the range at the bottom suggests that some individuals with severe deficiency of alpha-1 may have severely limited FEV1 values despite never having smoked as a result of progressive emphysema with alpha-1. On the other hand, looking at the two other boxes, ex-smokers in the middle and active smokers, fortunately very few in the registry, only 8% of registry participants were active cigarette smokers, you can see that the median FEV1 values are about 30% predicted, quite severely obstructed. And there are very few individuals among smokers, for example, who have preserved FEV1 values because cigarette smoking clearly increases, again, the inflammatory insult to the lung. Now, a word about natural history. The longest follow-up study of individuals comes from follow-up of those individuals who were tested during infancy at birth in the neonatal screening studies from Sweden that I discussed in part 1 of this series. And you can see that when Barnspang and Pittalainen followed these individuals at a mean age of 32 years and compared them to normal individuals of an age and gender matched group, some 126 PIZ individuals, you can see that, number one, there were very few smokers. That is to say, having the diagnosis of alpha-1 antitrypsin made at birth discouraged these individuals from smoking because they were counseled by their parents and others about the hazards of cigarette smoking. Again, one of the potential therapeutic impacts of making a diagnosis of these individuals early. Most importantly, however, the lung function of these individuals among the ZZ individuals, the SZ individuals in the middle, and the MM individuals were normal. Specifically, the FEV1% predicted values were all above 100% predicted. As you can see, the FEV1 FVC ratios were all above 0.7, the value below which we start to suspect airflow obstruction, and the transfer factor, or KCO, values were also above 100% predicted. So these individuals had normal physiologic lung function. In addition, for CAT scans, looking at the lung parenchyma as a sensitive way of exploring the presence of emphysema, these individuals at age 32 on average were also normal, suggesting that, again, at least among non-smokers or very few smokers, that emphysema is unlikely to develop in the first 3 decades of life It may, however, develop thereafter. Now, the best information available in terms of the rate of change of FEV1 over time comes, in fact, from the NHLBI registry that I've discussed with you already. And here, where those patients were followed for 7 years, we were able to plot the rate of change or decline of FEV1. All of us, of course, lose lung function annually as normal aging. Among men and women, that value is about 19 to 22 ml per year among normal non-smokers. But you can see that in the registry individuals, shown in the light blue bar, among never smokers, the FEV1 slope, that is to say the rate of change of FEV1 year over year, was on average 67 ml per year, 3 times faster than normal, 20 or 22 or so being normal. Among ex-smokers, it was about the same, 54 ml per year. That is not a statistically significantly smaller value. But among current smokers, recognizing that cigarette smoking increases the inflammatory burden and therefore is a bad actor, as we've discussed, the rate of FEV1 decline was on 109 ml per year, 5 to 6-fold higher than normal. Again, validating the risk of cigarette smoking in these individuals. This is not only a disease associated with morbidity, but also mortality. And in follow-up from the Larson series that I discussed earlier, when they followed 246 individuals for 11 years, the overarching mortality rate was 37%, most of whom died from respiratory failure as a complication of chronic obstructive pulmonary disease. Some patients, about 12 of them, dying from complications of cirrhosis. If we look at the survival curve from the NHLBI registry, shown here, with mortality on the vertical axis and time out to 5 years on the horizontal axis, you can see that over time the mortality rate was about 3% per year, quite agreeing with the Larson data from several years earlier. If we stratify survival, again on the vertical axis, mortality, and time on the horizontal axis by the patient's FEV1, the value of their lung function on entry into the registry, those who entered the registry with already severely impaired lung function and FEV1 less than 15% predicted, shown in yellow, described a mortality rate, as shown here, of 36% at 3 years. Quite a sober and worrisome prognosis. Those individuals who entered the registry with well-preserved or better preserved lung function, FEV1 above 50% predicted, described a relatively normal survival curve over the course of the 5 years of follow-up. When we analyzed, as we did in our institution, the causes of death among these individuals with a death review committee that reviewed every case in detail with hospital records, et cetera, you can see that most of these individuals died as complications of emphysema. About 10% died of complications of cirrhosis, and beyond that, the so-called standardized mortality ratio, the number of individuals dying in excess of age and gender-matched peers was not statistically significant. So the only excess causes of death in this analysis was, in fact, cirrhosis and emphysema, as would be expected from the pathophysiology that we've discussed. Interestingly, in a series by Tonish and colleagues who evaluated causes of death in never smokers with alpha-1 antitrypsin deficiency, you can see that fewer of these individuals, 45%, died of emphysema compared to the 72% in the registry that we just discussed, where more than 80% had been cigarette smokers, and more patients, 28% among non-smokers, die of cirrhosis than was the case in the registry, some 10%. The message being that if one doesn't smoke and therefore is not at risk of death from emphysema, that over time the risk of cirrhosis with advancing age may increase. And among individuals analyzed at postmortem by Sten Eriksson in a series from Sweden, perhaps the frequency of liver disease that was either clinically apparent or clinically quiescent was up to 40% in these individuals. So, in concluding our discussion of part 2, I'd like to suggest several key takeaway points. Number 1, alpha-1 antitrypsin deficiency may present with COPD as a prominent clinical manifestation. This may occur, of course, in active cigarette smokers because of the consequences of smoking we've discussed, but importantly, it may occur among never smokers as well. The rate of FEV1 decline, rate of emphysema progression is accelerated several-fold among active cigarette smokers with alpha-1 antitrypsin deficiency. Certainly the method of ascertainment, how these patients come to our attention, either because they're an asymptomatic family member or because they're highly symptomatic with liver or lung symptoms, will affect the outcome of these individuals. Those patients ascertained as family members with no symptoms may in fact have normal survival, whereas those patients coming to attention because of liver symptoms or lung symptoms may not. So thank you for your attention in part 2. In part 3, we'll continue this discussion as we talk about diagnostic strategies and therapy for alpha-1 antitrypsin deficiency.